You know, when we think about structural failure, like, I don't know, a building collapsing, we usually expect some pretty obvious warning signs.
Right, yeah,
Yeah.
like deep cracks in the drywall or something.
Exactly. Or, groaning support beams, maybe some alarms blaring. It's loud and it's highly visible. You expect to see the damage happening in real time.
You do, but the reality we are looking at today, it operates on a completely different frequency.
Yeah.
I mean, imagine if the foundation of that building was just quietly turning to chalk.
Wow. Just chalk.
Right. No alarms, no massive structural shifts that you can actually see from the street. Just the paint on the outside turning a pale, ghostly white, while the structural integrity underneath just silently evaporates.
And that is exactly the diagnostic reality of lichen sclerosus, or LS.
Yeah, it really is.
So, welcome to the deep dive. Today we're looking at a massive stack of sources, clinical guidelines, dermatological research, some really fascinating case studies, all surrounding a disease that, well, it operates in near total silence.
But it fundamentally alters the biological glue of human skin.
Right. And this deep dive is your shortcut to being well-informed about a condition that might be affecting millions in total silence. Millions of people dealing with intense discomfort and, like you said, progressive structural changes to the skin.
Often without a clear diagnosis for years, which is it's incredibly frustrating for the patients.
Oh, absolutely. So our mission today is to unpack exactly what LS is, why it happens, and where it shows up. Plus, we're going to get into the paradoxical truth about its primary treatment and how you navigate the long-term journey of this disease without just, feeling completely overwhelmed.
It's a lot to cover, but it's so important.
It really is. Okay, let's unpack this by looking at the fundamental blueprint of the disease. Like, what is actually happening at the tissue level here?
Well, at its core, lichen sclerosus is a chronic inflammatory autoimmune skin disease.
Okay, autoimmune.
Right. And when dermatologists look at the clinical presentation, the absolute hallmarks are severe pruritus, which is just extreme itchiness.
And the sources say that gets way worse at night.
Really dramatically worse at night, yeah.
Yeah.
And the other hallmark is hypopigmentation. So the tissue actually develops these very distinct porcelain white plaques or patches.
Porcelain white. That's such a specific visual.
It is. But the most critical factor, the thing we really need to focus on, is the progressive skin atrophy.
The thinning.
Exactly. The dermis is actively losing its structural integrity. It's thinning out. And while, technically this can appear anywhere on the body, the disease preferentially targets the anogenital region.
Right. The sources were very specific about that presentation.
Yeah, in female patients, it typically shows up in this classic figure of 8 pattern that encompasses the vulva and the perianal area.
And looking at the demographics of who actually gets this, it doesn't look like a standard bell curve at all.
No, not even close.
It's more like, I was thinking about it like a demographic roller coaster, right? Like, it hits the beginning of life really hard, specifically in pre-adolescent girls.
Yeah.
And then it just completely skips over the reproductive years. Like, the track just launches over that whole period of life, only to touch down again and peak in postmenopausal women.
It's a true bimodal distribution. And I should add, men do get it too.
Right. Usually on the foreskin or the glands, I think.
Exactly. But the female to male ratio is stark. It's somewhere between 3-to-1 and 10-to-1.
Wow. Okay. But going back to that roller coaster, to see a disease map so perfectly around the edges of a woman's reproductive years, skipping the middle entirely, I mean, why this specific demographic? Is it just a coincidence, or is there a hormonal smoking gun here?
What's fascinating here is that the clinical data strongly points to a hormonal microenvironment being the key factor.
Okay, so it is hormones.
Yeah, precisely because of that bimodal distribution, you have this massive spike in incidence right when estrogen is naturally low, pre-puberty and postmenopause.
Ah, that makes sense.
And we actually see this validated in pediatric cases. The research shows that between 25% and 31% of prepubertal girls with LS actually experience a significant improvement in their symptoms once they hit puberty.
Wait, really? Just from hitting puberty?
Yeah. Once their endogenous estrogen levels rise, the symptoms often improve.
So the introduction of estrogen physically alters how the local tissue behaves. It's like it puts the fire out for, what, a third of those kids?
Basically, yeah. And tissue analysis reveals the mechanism behind it. When researchers actually biopsy diseased vulvar tissue and look at it microscopically, they find a sharply decreased expression of estrogen receptor alpha.
Okay.
And on top of that, there's an almost complete absence of androgen receptors.
So the local tissue is it's isolated.
Exactly. It is essentially starved of normal hormonal signaling. And that seems to create this highly specific microenvironment where this particular type of autoimmune inflammation can just thrive.
That is wild. But then, if you look at the stats, about 15 to 20% of these patients are also developing extragenital disease.
Right, the extragenital presentations.
Meaning those same porcelain white patches and the skin thinning are showing up on their neck, shoulders, buttocks, thighs, even wrists.
Yeah, the wrists are surprisingly common.
So that tells me this isn't just about the local tissue environment in the genital area. The immune system is systemic. It's circulating, waiting to strike anywhere.
That's right.
But what actually tells it where to attack outside of that primary zone? Why the shoulder? Why the wrist?
Well, that brings us to a profound mechanism called the Koebner phenomenon.
The Koebner phenomenon.
Yeah.
Okay.
This is a process where disease-specific lesions form on previously healthy skin as a direct result of skin trauma.
Trauma, like an injury.
Yes, but trauma in the context of LS is incredibly subtle. We are talking about the friction from tight clothing,
Okay.
the act of scratching an itch, or occlusion, which is basically covering the skin in a way that traps moisture and irritants.
Wait, hold on. I have to push back on that.
Sure.
We all wear tight clothes. I mean, we all scratch an itch sometimes. Wait, so just wearing tight, occlusive clothing or scratching an itch can literally trigger an autoimmune response that fundamentally alters your skin structure?
It sounds crazy, I know.
If that were true for everyone, anyone wearing skinny jeans would have LS. There has to be a missing link here.
Oh, there absolutely is. The missing link is genetic priming.
Okay, genetic priming.
Right. The friction alone doesn't cause the disease. It acts as a trigger. Genetics load the gun, but the environmental factors like occlusion or friction pull the trigger.
I see.
The sequencing data shows a really strong link between LS and specific human leukocyte antigens, primarily HLA class II antigens. So the immune system is genetically predisposed to this very specific misfire.
So how does the friction actually pull that trigger, biologically speaking?
Well, when you scratch the skin or when you have chronic friction from tight clothes, you cause micro tears in the dermis.
Micro tears.
Yeah. And those micro tears release inflammatory cytokines. Now, in a patient without that HLA class II marker, the body just heals the minor damage. No big deal.
Right, just normal wear and tear.
Exactly. But in an LS patient, those cytokines act like a biological flare gun. They draw circulating autoantibodies directly to the site of the friction.
And what are those autoantibodies looking for?
They're hunting a very specific target. It's called extracellular matrix protein 1, or ECM1.
ECM1. That's essentially the biological adhesive in the skin, right?
Yes.
Like it's the protein binding the collagen and elastin fibers together to give the skin its bounce and resilience.
Exactly. It's the glue. And the data shows that up to 75% of LS patients have autoantibodies that are actively targeting and degrading that ECM1 adhesive.
Oh, wow. So the structural collapse, the thinning, the white patches, that's the direct result of the immune system literally dismantling the scaffolding of the skin.
You've got it. And this tendency for the immune system to go rogue, it's not isolated. Almost 19% of women with LS have other comorbid autoimmune diseases.
Really? Like,
Yeah.
what?
The most common is Hashimoto's thyroiditis. That affects over 10% of the patient population alone.
That's a huge overlap. Okay, so the immune system is actively dissolving the biological glue holding the skin together. And if simple mechanical friction or scratching can act as a flare gun to draw those autoantibodies to a specific site, I mean, that makes the rules around how we treat this disease incredibly high stakes.
High stakes is the perfect way to describe it.
Because think about it, you're dealing with severe skin thinning, atrophy. So your instinct, and the instinct of probably anyone listening to this, would be to run as far away from ultra-potent topical corticosteroids as possible.
Because of the side effects.
Right. The primary universally known side effect of prolonged steroid use is skin thinning.
Yes, steroid atrophy is a well-known phenomenon.
But here's where it gets really interesting. Across all the clinical guidelines in our stack of sources, the absolute first-line gold standard therapy is an ultra-potent topical corticosteroid, usually clobetasol propionate, 0.05%.
That's the one.
People are usually terrified of steroids because they cause skin thinning. But here, the disease itself is thinning the skin, and the steroid is actually what stops the atrophy. It's a total paradox.
It is, until you connect it to the bigger picture. If we connect this to the bigger picture, the paradox resolves when you look at the mechanism of action.
How so?
The ultra-potent steroid isn't stopping the atrophy by, actively building up the dermal layers. It stops it by slamming the brakes on the immune system's localized attack.
Oh, I see. It shuts down the autoantibodies.
It forces the T cells to stand down so they stop attacking that ECM1 biological adhesive. Once that localized immune attack is neutralized, the skin's natural healing mechanisms can finally catch their breath and stabilize the architecture.
That makes perfect sense. But because clobetasol is in the absolute highest potency class, the margin for error must be razor thin.
Oh, it's microscopic. Literally, the clinical guidelines enforce a very rigid measurement for application called the fingertip unit, or FTU.
Right, the FTU. To visualize this for you listening, an FTU is the amount of ointment squeezed from a standard tube that covers just the length of an adult fingertip.
Just from the tip to that first crease on your finger.
Yeah, which equates to roughly 0.5 grams. Or, to picture it another way, a dot of ointment only 3 millimeters wide.
It highlights that very little is needed. A standard 30-gram tube of this stuff is meant to last a patient a full 3 months of continuous treatment.
3 months from one little tube. And the guidelines specify ointment over creams, right?
Yes. Creams contain preservatives and stabilizing agents that can act as contact irritants. And as we know from the Koebner phenomenon, irritants can trigger further inflammation, so ointments are much safer.
But when that precise dosing is misunderstood, or just ignored, the consequences scale incredibly fast.
They really do.
There was that case study in the data that completely reframed the stakes here. The 10-year-old girl.
Yes, that case study is a crucial warning. She presented with severe vulvar and perianal LS.
And she was prescribed the standard clobetasol 0.05% ointment. But over just a 2-month period, she went through 60 grams of it.
60 grams in 2 months. She used double the medication in 2/3 of the recommended time.
You read a case like that and you have to ask, how does a 10-year-old end up using that much ultra-potent steroid in 8 weeks?
It usually comes down to a desperate search for relief from the itching. That pruritus is agonizing, combined with, frankly, a lack of clear communication from the prescriber about the sheer potency of the drug.
Right, you think more cream means faster relief.
Exactly. And her local LS symptoms did resolve completely under that massive pharmaceutical assault, but the collateral damage was severe.
She developed Mark-Sonst striae, right? Deep, irreversible stretch marks.
Yes, perianally and across her inner thighs due to the rapid steroid-induced atrophy of the healthy surrounding tissue. But the real crisis was systemic. It was invisible. She suffered profound adrenal suppression.
Let's unpack that, because adrenal suppression sounds like a catastrophic systemic failure.
It basically is. When you apply massive amounts of ultra-potent synthetic cortisol to the skin, especially skin where the barrier is already broken down by LS, that steroid absorbs directly into the bloodstream.
Okay, and then what happens?
The hypothalamus and the pituitary gland sense this overwhelming flood of synthetic cortisol, so they react logically. They signal the adrenal glands to shut down endogenous cortisol production. They think, hey, we have too much, shut down the factory.
So her body simply forgot how to produce its own stress hormones.
Exactly. Her tests showed severely low ACTH, which is adrenocorticotrophic hormone, and a completely impaired cortisol response. And without your own cortisol, your body can't manage inflammation, it can't regulate blood pressure, you can't survive severe acute illnesses.
Yeah, it is terrifying.
It took 15 agonizing months on oral hydrocortisone for her adrenal glands to finally recover and function normally again.
Wow. And the sources list several specific risk factors for triggering this kind of systemic absorption. The total amount used, the duration, the age of the patient, because pediatric skin is thinner.
Right.
And specifically, the use of occlusion. Which actually brings me to a highly specific question regarding extragenital LS that we should clarify for the listener.
Okay, let's hear it.
So, given this extreme risk of systemic absorption, and knowing that occlusion acts as a mechanical trigger for the Koebner phenomenon, if a patient has really thick, stubborn extragenital plaques, like on their neck or shoulders, is there ever a scenario where topical corticosteroid therapy under occlusion is indicated to treat extragenital lichen sclerosus, like to force the medication into those resistant plaques?
Based on the entirety of the dermatological literature, the short answer is no. Absolutely not. It is contraindicated.
Never use occlusion.
Never. You face a dual risk that far outweighs any localized benefit. First, by sealing the area with a dressing or tight clothing, you exponentially drive up the transdermal absorption of the steroid.
Which puts you at immediate risk for that systemic adrenal suppression we just talked about.
Exactly. And second, the occlusion itself traps heat and moisture, which acts as a mechanical trigger for the Koebner phenomenon. So you risk exacerbating the very architectural destruction you were trying to halt.
Wow, okay, so occlusion is universally the enemy. It's a catalyst for the disease and an accelerant for the worst side effects of the treatment.
Perfectly stated. The protocol for extragenital eclass remains the precise, conservative application of potent steroids, leaving the area unoccluded to breathe.
Good to know. But what happens when that precise, unoccluded steroid application fails? Because some patients are simply steroid resistant.
Right. When steroids fail, dermatologists pivot to second-line defenses, specifically topical calcineurin inhibitors or TCIs.
Medications like tacrolimus or palmicrolimus.
Exactly.
So if we're pivoting to calcineurin inhibitors, we're basically dropping the broad-spectrum, scorched earth anti-inflammatory approach of the steroid and bringing in a sniper to target the local T cells, right?
That is a great way to conceptualize it, yeah. TCIs are non-steroidal immunosuppressants. They calm the local immune system by halting the production of inflammatory cytokines right at the source.
And they don't carry the risk of skin thinning.
Right, which makes them an incredible tool.
There's
However,
always a however.
there is. The sudden shift in localized immune signaling causes a notorious side effect: intense, acute burning upon initial application.
Oh, man. For a patient already dealing with a painful, itchy skin barrier, that must be rough.
It requires significant resilience to push through that initial burning phase. Now, if the plaques resist both steroids and TCIs, there are other options.
Like phototherapy, right, UVA1.
Yes, or intralesional triamcinolone injections, where they inject the steroid directly into the plaque.
Okay, I want to shift focus to the male demographic for a moment, because while the female-to-male ratio is stark, the physical mechanics of the disease in men present a unique set of challenges, especially when it targets the foreskin.
Yeah, in male patients, if rigorous topical steroids fail, the almost universal recommendation in the urological guidelines is circumcision.
Because of phimosis.
Exactly. The architectural distortion caused by LS frequently leads to phimosis.
Let's explain the structural mechanics of phimosis for a second, because it highlights exactly why circumcision becomes almost mandatory in these cases.
Sure. Phimosis occurs when the chronic inflammation and scarring turn the normally elastic tissue of the foreskin into a rigid, tight ring.
Right.
It becomes physically impossible to retract the foreskin. This traps moisture and irritants against the compromised tissue, which acts as a constant chemical and mechanical irritant. It's occlusion, basically.
A self-sustaining cycle of inflammation.
Right. Circumcision physically removes the diseased tissue and the source of the occlusion, which is highly effective at halting the disease progression in men.
So what does this all mean? That structural reality brings us to the ultimate stakes of this condition. Lichen sclerosus is not just a rash that goes away. It requires lifelong management and intense respect for the skin's barrier.
Without lifelong maintenance, the architectural distortion can be devastating.
We're talking fusion of the labia, burial of the clitoris, urethral strictures that physically block the flow of urine.
And beyond the structural damage, the biological stakes are even higher. The chronic inflammatory cycle carries a lifetime risk of progressing to squamous cell carcinoma or SCC.
The sources put that risk between 2.6% and 6.7%, right?
Yes, but the goal of treatment isn't necessarily a cure, since there isn't one, but remission.
Right, and total remission is achievable.
Absolutely. Once you halt the active immune siege, patients transition to maintenance therapy. This might mean applying that tiny FTU dose of steroid just once or twice a week.
Combined with gentle skincare, fragrance-free emollients, no harsh soaps, and loose breathable clothing.
Exactly. You give the patient a completely normal quality of life by preventing that occlusion and friction.
So, to summarize, LS is a complex mix of genetics, hormones, and autoimmune misfires. But it is highly treatable with precise, carefully managed steroid use and definitely avoiding unnecessary occlusion.
Which is key. And, this raises an important question regarding the future of how we understand this disease.
Oh, what's that?
Well, looking at the cutting-edge sources, there is a huge focus on oxidative stress.
Oxidative stress, okay.
Yeah. Ellis lesions show incredibly high levels of lipid and DNA peroxidation. The cells are basically under siege from free radicals due to the chronic inflammation.
Wow.
Furthermore, they've found that a specific enzyme mutation, apobexididine deaminases, which are linked to DNA replication and aging, is hyperactive in the specific cancers that evolve from lichen sclerosus.
So the localized inflammation is generating so much oxidative stress that it's mutating the DNA repair enzymes themselves.
That's the theory. So I leave you with this to ponder. Could understanding how our skin cells repair DNA damage under oxidative stress be the ultimate key?
The key to preventing it from ever turning into cancer.
Exactly. If we figure that out, we might not just be managing symptoms anymore.
That is an incredible thought to leave on. Thank you for joining us on this deep dive into lichen sclerosus. Keep asking questions, stay curious, and we'll catch you on the next one.